Hello and welcome to the Sarcoma Foundation of America's panel review of the 2024 American Society of Clinical Oncology annual meeting. My name is Christy Arishjan, and I'm the Program Manager for Engagement and Research at SFA. Thank you for taking the time to join us and hear what our panelists have selected to highlight as key findings in sarcoma presented at the meeting. Before we begin, I'd like to briefly go over the format and logistical details of this webinar. I'll be serving as the moderator for today's session. We have two panelists who each have selected several abstracts from the meeting and will present key findings and conclusions of those abstracts today. Following their presentations, we'll open up to a questions and answers session. As moderator, I will pose questions submitted to our panelists. At any time during today's session, you can submit your questions by entering them in the questions field at the bottom of your screen. Please remember, our panelists will not be able to answer questions related to your specific medical situation, so make sure that they're related to the topics raised during the session. The information in this webinar is for educational and informational purposes only. It's not a substitute for medical advice from your physician. Today's session is being recorded and a link will be posted to SFA's website. Finally, as a reminder, all participants are muted and questions must be posed in the questions and answer box. Now I'd like to introduce our speakers. Dr. Herbert Long is an associate professor in the Department of Clinical Oncology at the Chinese University of Hong Kong, with additional roles as Deputy Medical Director of the Phase 1 Clinical Trial Center and founder of the Prince of Wales Hospital Adult Sarcoma Multidisciplinary Team. Dr. Long has co-founded organizations like the Asia Pacific Oncology Drug Development Consortium and the Asia Pacific Coalition Against Lung Cancer. He also serves as a member of the board of directors of the Connective Tissue Oncology Society. Dr. Avutu is a medical oncologist in the departments of medicine and pediatrics at Memorial Sloan Kettering Cancer Center and is a founding member of the adolescent and young adult oncology program there. His clinical expertise is in sarcomas, particularly bone tumors and soft tissue sarcomas commonly found in adolescents and young adults. His research interests are in early phase clinical trials using novel therapies and health outcomes research focusing on patient-reported outcomes and improving clinical trial opportunities and enrollment for adolescent and young adults. He serves on multiple national and international cooperative groups focusing on sarcomas and adolescent and young adult oncology. Thank you both for joining us today, and especially to Dr. Long for your willingness to share your time despite the 12-hour time difference in Hong Kong. At this time, I'm going to transfer over the controls to Dr. Avutu and let him begin sharing this information.
Thank you, Christy, and thank you to the Sarcoma Foundation of America for this opportunity. I'm really excited to share some of the incredible research that was presented at ASCO. As mentioned, my name is Vishu Avutu. I'm one of the assistant attendings here at MSK with a specialty in adolescent young adult sarcoma. So just to begin, I don't have any conflicts of interest to disclose. And just a disclaimer, so the data that I will be sharing as well as the slides are lifted from ASCO, and they're being used at the courtesy of the authors and investigators for the purposes of this webinar. The choice to discuss any of the following abstracts are based purely on my personal assessment as well as our groups, based on their academic merit and impact on our community, but doesn't reflect the views of ASCO or SFA or any of the authors or sponsors. So the format for my presentation will kind of go through this general layout. We'll both first focus on key takeaways with a delve into the background, a little about the study design of each of the trials, patient demographics, result safety, any adverse events, and really kind of putting it into the context of how this may impact either your care or your loved one's cares and any concerns that are still pending. These are the four that I have chosen to highlight. I will be very transparent. The third abstract, I am the lead investigator on, but we do think that the impact is relevant, and so that's why I will be discussing this. And they cover a wide variety of different sarcoma histologies. So the first one I will focus on was a Stand Up to Cancer trial in combination with SARC. This is a randomized trial of neoadjuvant radiotherapy and surgery with or without pembrolizumab for soft tissue sarcomas. This is led by David Kirsch. And the key takeaways really from this study were that the addition of pembrolizumab to preoperative radiotherapy and surgery increased disease-free survival in patients with high-grade undifferentiated pleomorphic sarcomas, or UPS, or liposarcomas. The treatment with pembro, however, did increase grade 3 or 4 adverse events, but importantly, no new signals of safety were observed. So real quickly, the background, radiotherapy and surgery are often used to achieve local control, and this is often successful in about 90% of all cases of extremity soft tissue sarcomas. There is, however, a risk of developing metastatic disease, particularly in very large and high-grade soft tissue sarcomas, ranging to about 50% in certain cases. SARC-028, this was a multi-center phase 2 trial of pembrolizumab monotherapy in advanced or refractory soft tissue sarcomas. This demonstrated a signal specifically in the cohorts of UPS and LPS. There's even some preclinical data to suggest synergy between radiotherapy and immune checkpoint inhibition, and we've actually seen this in the clinic as well. The study design is a relatively straightforward randomized control group. So you have to have had a grade 2 or 3 UPS or LPS, and it had to be 5 centimeters or larger, and usually the extremities. Patients were randomized to either the standard of care, which was pre-op radiotherapy, about 50 gray in total, which is relatively considered standard, followed by surgery about 4 to 6 weeks later, followed by surveillance. No additional therapy was given. In the experimental arm, the same thing was done, except that pembrolizumab was given in the preoperative setting and then continued up to a total of 1 year in the adjuvant setting. And then active surveillance was undertaken. Patient demographics, so this was a large trial with about 143 patients enrolled, 127 were evaluable. There were 2 cohorts, the control and experimental, and 72, 71 reflected there. Both groups did have a slight male preponderance, and I would say the large proportion of patients had a grade 3 histology, so almost 2/3 of all patients enrolled in both the control and experimental cohorts. Of those, a large percentage, not almost 90%, were UPS with a much smaller cohort of LPS. So this is a typical Kaplan-Meier curve. I know this is a very medically savvy group, so I won't go into too much detail other than to show that the hazard ratio is quite promising with a significant p-value, suggesting that the 2-year disease-free survival was significantly improved in our experimental cohort. Again, this is the cohort that received preoperative plus adjuvant pembrolizumab in addition to the radiotherapy and surgery that was given in the standard group. I would just comment that this is in all evaluable patients, so patients who met all the endpoints. There was a separate intent to treat, and again, we saw similar results that were presented for that group. I am not showing some of the other complicated and relatively rich data that was presented. For example, they broke this down both by UPS and LPS histologies. Again, the hazard ratios were significant, suggesting pembrolizumab benefit in both of those groups. The one more fine detail that I do want to pull out is this difference between grade 2 and grade 3 soft tissue sarcomas. As you can see here, the significance was primarily driven by the higher grade 3 as opposed to the intermediate grade 2. You can see the curves on the right side really kind of coming together. I would note that this trial was not designed to detect these statistical differences, so this should be taken into consideration. In terms of safety, as mentioned, there were more grade 3 or 4 adverse events with pembrolizumab, about a little over 50% versus 30%. And again, almost half of all individuals had at least some adverse event, even grade 1, to pembrolizumab. Very importantly, there was no difference in major surgical complications, meaning all patients were able to get through radiotherapy and surgery for the most part without having significant issues towards the end of it. These are the treatment emergent adverse events. I know this is a lot of information, but I think I would just draw your attention to kind of some of the overall numbers. So about, again, half of all patients in the experimental group had fatigue compared to only about a quarter in the control group. There are some other differences, but I think for the most part, this is still a relatively very well tolerated regimen. We give pembrolizumab as standard of care to many of our patients with UPS specifically. So to put this into context and some of the concerns that are still remaining. So historically, perioperative cytotoxic chemotherapy, often with doxorubicin, ifosfamide, and mesna, is considered the standard of care and really the only proven treatment to improve overall outcomes and disease-free survival in many of our soft tissue sarcomas. This is old retrospective data. There's a lot of controversy surrounding that, which I will not get into at the moment. But this study just, I think, highlights that the potential of using immunotherapy in a novel setting to improve outcomes. We are still awaiting final publication of all of the study data, so there are still some questions that do need to be answered. So for example, for very large tumors, particularly above 10 centimeters, where we think the risk of distant metastases is very high, is this pembrolizumab plus pre-op RT comparable to cytotoxic chemotherapy, whether given neoadjuvantly or adjuvantly? We don't know whether it's non-inferior or superior even to AIM. So that's an important question. We know that AIM reduces the risk of this. We still don't quite yet know, because the data is not fully mature, what this will be. And then we don't know exactly how the two arms were balanced. For example, we don't know if there were slightly higher, larger size tumors in the experimental arm versus the control, or vice versa. So knowing that information will be very critical. And whereas major surgical complications were not seen, we do still want to understand how many patients received adjuvant pembro, et cetera, to really gauge how people recovered afterwards. There are some other key features. So for instance, I did mention size as being a really important one, but even the type of liposarcoma. So at our group, we're really thinking of using this pre-op RT plus pembro primarily in UPS, because LPS was such a smaller cohort. But again, I think the jury is still out about how this is going to sequence into many of our treatment decisions. And again, is this really for well-D-diff liposarcoma, or does this also include some of our rarer liposarcoma targets? I suspect when the final paper is published, we'll have more answers that will help allay some of these concerns. Jumping on ahead to SARC-037, this is a little pediatric focused, but this was looking at the phase 2 results of trabectedin given as an hour infusion in combination with low-dose irinotecan in patients who have relapsed refractory Ewing sarcoma, presented by Dr. Patrick Grohar. So the takeaway from this is that this combination of trabectedin as a 1 hour infusion plus low-dose irinotecan is active, and that the responses when seen can be quite durable. This combination is, again, quite safe, and no new safety signals were observed, importantly. So the background of Ewing sarcoma is primarily that the oncogenic driver is this new oncofusion that we see between EWS and FLI1. EWSR1, FLI1 being the most common, but there are a couple of other EWS proteins that can be seen in partnership with FLI1. Trabectedin has been known to reverse some of the cellular reprogramming that occurs when this oncofusion is present. We know that this oncofusion is what drives this, and this hijacking of the cellular machinery is responsible for growth and metastases. There was initially a phase 2 study of a 24-hour infusion of trabectedin that was negative. Data and study that has come afterwards suggested that there is a threshold that has to be met before trabectedin can sufficiently inhibit the oncofusion reprogramming, and that in this 2012 phase 2 trial, so over a decade ago, that threshold was not achieved. This 1 hour infusion, as in lieu of the 24-hour infusion, does appear to achieve that higher concentration that we believe overcomes that threshold. And then there's clearly some synergy between trabectedin and irinotecan. So there was a phase 1 precursor that was presented last year at ASCO, in which 4 partial responses out of 18 patients was seen. So again, promising. This was a multi-center phase 2 study over 6 institutions. Patients had to be old, at least 6 years of age, and have to have had an EWS FLI1 fusion by molecular testing. Typical adequate performance status and organ function was required, as is true for most of our phase 1-2 trials. As mentioned, 18 patients were enrolled with a median age of 21 years. The range is seen here with an upper limit of 43, relatively equal between male and female. And then this median prior line of therapy is important. So the median was 4 with a range of up to 7. So this is a relatively heavily pretreated group of patients. About 2/3 had seen prior irinotecan, usually in the context of irinotecan Temodar, which is one of our canonical salvage therapies for Ewing sarcoma. Of note, I would just mention from the demographics, about 17% had primary pelvic tumors. We do know that these are higher risk tumors, often with worse outcomes than some of our more classic ones. So here's a waterfall plot. Anything below the median 0 line is usually a good thing. Anywhere in the 20 to plus 20 to minus 20 is considered relatively stable. Anything below minus 30 is really a partial response. So everything in blue is a good thing. So the objective response rate, which looks at all partial responses, was 5 out of the 18, or about 28%. If you include the patients who were treated on the earlier phase 1 trial presented last year at the same dose that all 18 of these patients were treated on, that number increases to about 8 out of 23, or about 35%, and then with a partial response. Looking a little, this is called a swimmer's plot. So the longer these horizontal lines are, the better. Some of these I will mention are still ongoing, but the progression-free survival is 2.9 months. I know for many of you that does not seem good, and it is not, but you have to remember that this is in the context of heavily pretreated patients. So when they don't have a ton of other options, this is actually relatively promising, albeit, disappointing. And then the other two numbers I think are really critical. So the median time to response was 2.6 months. So sometimes it does take time before we see responses, but the duration of response was much more heartening with about almost 8 months. Progression-free survival rates for 4.5 and 6 months are listed there, close to 40 to 47%. Safety-wise, 2 patients had to stop treatment due to toxicity, one for prolonged thrombocytopenia, so low platelets, and then one for prolonged neutropenia or white cells, and with elevations in AST and ALT, so some form of liver dysfunction. One patient did require dose reduction. In terms of the adverse events, so these are pretty typical of more reflective of trabectedin, but with some irinotecan flavor thrown in. So again, typical liver issues, tiredness, nausea, some bone marrow or blood count issues, but relatively expected. Putting this into context, so there was a large randomized trial that was pivotal in terms of helping us understand how to sequence salvage regimens after relapse. So this was called the Recur trial, published a few years ago and still with some ongoing data. But the best salvage regimens after first-line VAC-IE was considered to be high-dose ifosfamide, which is better than irinotecan temozolomide, which is relatively equivalent to cyclophosphamide topotecan, which is clearly better than gemcitabine docetaxel. As you can see here, trabectedin is typically not considered one of the salvage regimens we use, in part because the initial study a decade ago was negative. So we don't know how this study will fit in terms of where it fits into these salvage regimens. In some ways, I think that it likely would go before gemcitabine docetaxel, especially because of these partial responses. But I don't know that we'll ever have these kind of head-to-head comparisons like this Recur trial did, but it is an important thing to note. Additionally, given that a lot of these patients will have seen anthracycline, so doxorubicin, some of them may have already experienced some cardiotoxicity from that drug specifically, and trabectedin is known to potentially cause cardiac damage. So knowing a little more information about the cardiac health of the patients, as well as any toxicity that was seen, will be critical. And again, this focused on EWS FLY1, which is the most common form of fusions that we see in Ewing sarcoma, but there are non-canonical fusions that we are seeing at a slightly higher rate. So specifically CIC rearrange or CHICDUX4, B-core rearrange, CCNB3, PAX1 fusion, and FATC2. We don't know whether this would be effective in those non-canonical fusions. And as I mentioned, how do we think about sequencing this in our salvage regimens, and where is the role of TKIs, so such as regorafenib, cabozantinib, how do those also factor in? Because we know those TKIs are also effective in the treatment of refractory Ewing sarcoma. I will move on to now the phase 1 study of azenosertib, which is an oral WEE1 inhibitor in combination with gemcitabine in patients with refractory osteosarcoma. The key takeaway from this was that this combination appears to be an active regimen in treating a relapsed osteosarcoma. So this was triple the historical rate from prior phase 1 studies, which established a baseline of 12% event-free survival at 16 weeks. This increased it to about 40% at 18 weeks. Again, the combination was safe and tolerable, with the primary symptoms being myelosuppression and GI symptoms. So the background for this is osteosarcoma relies on the cell cycle checkpoint mechanism, and then the WEE1 kinase specifically is a master regulator of really the G2M, but it does have a role in the G1S cell cycle checkpoints. You can think of it almost as osteosarcoma cells have damaged DNA, as all cancer cells do, and they rely on the ability to repair that DNA to maintain integrity and allow for growth and metastasis. By abolishing these cell cycle checkpoints, we get rid of that ability to repair, and therefore we cause lethal synthetic damage, and these cells will die off. When you use chemotherapy, for example, gemcitabine, that causes DNA damage, you can almost supercharge that process. In preclinical studies that were done, both at our institution and institutions across the country, gemcitabine was considered to be the best synergistic partner for this class of WEE1 inhibitors. The study design, this was a multi-center international phase 1 study. It's a classic 3+3 with about 3 to 6 patients per dose level or cohort. A total of 5 dose levels were explored before we achieved maximum tolerated dose. Patients had to be greater than 12 years of age or equal with measurable disease for RECIST criteria. What this means is that they had to have disease outside of bone. So usually this was pulmonary disease. Again, adequate performance status and no prior treatment with a WEE1 inhibitor. Patient demographics, 31 patients were enrolled in total and 28 were evaluable. Median age was 27 with a range of up to 76. This is notable because most osteosarcoma trials don't include our older patients. So we were fortunate enough to include that here. Almost an equal split between men and women. And again, this is a heavily pretreated with about 3 median prior lines of therapy, up to 9. And then prior gemcitabine treatment, about a third of them had already been exposed, usually in the context of docetaxel. This is, again, the Kaplan-Meier curve. This is a phase 1, so there's not a comparison curve, but the 18-week event-free survival, about 39%. Again, this is a tripling as of the Children's Oncology Group baseline cohort. This is called a spider plot. So basically anything below this dotted line of plus 20% is usually a good thing. In osteosarcoma, generally, we don't see partial responses. We usually see stability of disease because of the nature of the tumor itself. And as you can see here, there's a good portion in the stable disease, about 61%. There are 2 patients. Now I can tell you that one of these patients has come off trial, but one of the patients here is ongoing, still on treatment now, well and beyond their 1 year. In terms of safety, most of the dose-limiting toxicities we saw in phase 1 was related to myelosuppression or low platelets seen in the first cycle. This is likely synergistic between the 2 different drugs, but primarily driven by gemcitabine. No new drug-drug interactions were seen, and therefore we think at the end of this that the MTD, or maximum tolerated dose, is 150 milligrams of azenosertib given 5 days on, 2 days off, and then gemcitabine at 800 milligrams on day 1, day 8 of a 21-day cycle. The adverse events from this combination are relatively straightforward. The vast majority, as I mentioned, had thrombocytopenia or low platelets. Fatigue and low blood counts were also seen, with a little less GI, upset stomach, nausea, etc. Context and concerns. So unfortunately, osteosarcoma, there are not very many salvage regimens after initial MAP chemotherapy. This is usually ifosfamide etoposide, perhaps gemcitabine docetaxel, and then really the TKIs that have come on in the recent few years. So one of the big questions we have, of course, is gemcitabine is considered to be active in the management of osteosarcoma, but it's not really clear how good it is. So one of the questions is, what role did gemcitabine play in this combination? Did it actually kill cancer cells by itself, or was it really sensitizing the damage, DNA damage of the cancer cells? And of course, we've seen, unfortunately, a few phase 1s that were promising, and unfortunately, in larger phase 2, we don't see that same promise. So this will be very important that this is confirmed in a phase 2 trial. That trial is in process of being planned. It'll hopefully be run out of Alliance or Children's Oncology Group and available to all patients in the US and Canada. And then, of course, if it's positive, how do we think about sequencing this in between our current salvage therapies? I know I'm running a little low on time, but I will try and be relatively brief in the final abstract. So this is a phase 2 multi-center first-line treatment of paclitaxel and avelumab in inoperable angiosarcoma, so treatment naive. This was presented by Dr. Kim. And the key takeaways from here are that paclitaxel plus avelumab, so a chemotherapy plus immunotherapy or immune checkpoint inhibition, appear to be active with an objective response rate. Again, this is partial responses of about half of all patients, with a progression-free survival of 6 months and an overall survival of over a year at 14.5 months. The combination is safe, no new safety signals, but about a little over half did have grade 3 or higher adverse events. So the background for this is that weekly paclitaxel is one of the standard of care regimens. It's probably considered one of the best. And the objective response, unfortunately, ranges all the way from 16 to 45%, depending on the exact trial you're looking at. The median progression-free survival, anywhere from about 4 to 7 months. Overall survival, 8 to 20 months. Many trials have now shown that there is a subset of angiosarcoma that has a higher tumor mutational burden, or TMB, but variable PD-L1 expression. Now, that TMB is important because TMB usually signifies a potential response to immunotherapy, specifically ICI, like avelumab, like pembrolizumab, like nivolumab. Furthermore, there is a cluster of angiosarcomas that we consider to be UV exposed. So, for example, usually on the skin, usually scalp, face, and those typically have these high TMBs. There was an alliance trial, AO91902, arm 3 of cabozantinib plus nivolumab, that did demonstrate significant anti-tumor activity in pre-treated angiosarcoma. So again, this study was looking at treatment naive. The alliance trial looked at pre-treated. There was no difference between scalp face angiosarcoma versus other anatomical angiosarcoma, despite having these differences in tumor mutational burden. Study design, this is a multi-center phase 2, patients above the age of 20 that again had inoperable, so locally advanced or metastatic angiosarcoma. They had to have adequate performance status and organ function, and they could not have received prior immunotherapy nor chemotherapy unless that chemotherapy was given more than 6 months prior to needing treatment on this trial. 33 patients were enrolled, 32 were evaluable. Median age was about 64. This did again have a preponderance of male, which is not always true of angiosarcoma trials because we do see radiation-associated angiosarcoma of the breast in many women, unfortunately. So this was slightly atypical. Of those, about a third had primary scalp angiosarcoma, so that cohort of UV-exposed high TMB potentially angiosarcoma patients. This is again a waterfall plot. As you can see, there is a significant portion, again 50%, that had a partial response or better. In fact, there was one complete response and a second that almost got to a complete response. Safety-wise, there was one sudden death, but it was not believed related to treatment. And then there were 3 who discontinued treatment either due to hyperbilirubinemia, so liver issues, pneumonitis, so usually related to avelumab, and then hyperglycemia, again, potentially related to avelumab. Dose modification or delay in treatment was required in 13 patients. To put this into context, so at ASCO, again, there was another alliance trial presented, this one looking at paclitaxel and nivolumab. So again, nivolumab versus avelumab, similar but slightly different. And in that study, that combination was not better than paclitaxel by itself. Now, again, this was a trial just looking at paclitaxel plus avelumab, so slightly different trials. But if you look at some of the subset analysis, and this alliance trial was not powered to do this, so this must all be taken with a grain of salt, the progression-free survival of patients with scalp or face angiosarcoma treated with the combination was double if they were just receiving paclitaxel by itself. The progression-free survival of patients with scalp or face angiosarcoma was significantly longer than those who did not have scalp or face angiosarcoma, both treated with the combination. One of the possible reasons for this is that in this trial, the alliance trial specifically, paclitaxel outperformed what we expected from historical controls, so we're not quite sure how to explain that. So some of the concerns based on this: one, how do we try and adjudicate these discrepancies when we see activity with the combination, but then there's a trial showing that the combination is no better than paclitaxel? Should we try and separate out scalp and face angiosarcoma from other anatomical sites to preferentially give them immunotherapy in combination? How do we stratify this? Is it just by anatomical site? Should we look at tumor mutational burden? We know PD-L1 expression does not appear to correlate. So kind of some of those other factors will be really critical. So with that, I just want to thank again all of our attendees and our Sarcoma Foundation of America, but specifically to our patients, families, and investigators who make all of this possible. So on their behalf, thank you all. And I'll hand it over to Dr. Herbert now.
Dr.
Herbert,
Long,
you're muted.
Sorry. Thanks very much, Vishu. That was a very good overview of some of the very important abstracts that was presented at ASCO. And I would like to again thank the Sarcoma Foundation of America for inviting me to also contribute to this webinar. And I've been tasked to talk about some of the other abstracts. And for the purpose of my presentation, I would focus mainly on some of the GIST abstracts that were presented, as well as one other important abstract that was presented as one of the oral presentations during ASCO. So I'm Dr. Herbert Leung. I'm a medical oncologist based in Hong Kong. It's now 6:33 a.m., so I'm a bit more awake than when I first logged on, and I'm very happy to be able to join all of you to discuss some of these abstracts. And these are my disclosures. So similar to what Vishu has presented, in actual fact, the slides are taken from ASCO, and certainly the copyright of these slides are belonging to the original authors as well as ASCO, and certainly we're using some of these slides by courtesy, mainly because of the fact that this is by virtue an academic as well as patient educational event. The choice of the abstracts that are being discussed is really based on my own assessment and does not reflect the views of ASCO, of which I was serving as a scientific committee member for this year's Congress. And I've highlighted three interesting GIST-associated abstracts that were presented at ASCO this year, which I think is worthwhile making sure that the patient community is also aware of some of the latest advances and developments. The first abstract is an abstract called STRATA-GIST, which is a first-in-human study of a compound known as IDRX42. And this is in patients with metastatic GIST, which have had prior treatment with other tyrosine kinase inhibitors, and this was presented by Dr. Patrick Scholfsky. The second abstract I'll present is a phase 1 study of a compound known as NB003. This is a broad spectrum KIT as well as PDGFR alpha inhibitor. This was presented by Dr. Lee, as well as a third abstract with a compound known as overembatinib in a specific type of GIST, which is the STH deficient GISTs, and this was presented by Dr. Chiu. So going back and really sort of laying the landscape of what GIST treatment approach has been like over the few years, we're all aware of the fact that with GIST, it's one of these sarcomas where there is clear indication for the use of targeted approaches and targeted therapy. And certainly with the use of imatinib or Gleevec in the first line setting, it has really changed the landscape and outcomes for our GIST patients. And subsequent to this, we normally take a relatively pragmatic approach with second-line treatment, third-line treatment, and we also actually have fourth-line treatment being approved. And you can see here from the diagram on the left, with the use of further treatments, we are able to have a longer duration of response and disease control for the patients. But inevitably, as we move on to the next lines of treatments, we realize that the durations of treatments are relatively short. And this is to do with the fact that as patients are being exposed to the different agents, the tumors themselves get smarter, and in actual fact, they develop resistant mechanisms, of which may or may not be covered by the second, third, or fourth line agents. And we also know that with more of these agents now being available, in actual fact, we do see that in actual fact, some of these agents are particularly useful in particular mutations and alterations. And for example, Dr. Bauer and colleagues presented some of their data looking at the use of ripretinib. And interestingly enough, it does seem as though in patients who have, say, exon 17 or 18 KIT mutations, the use of ripretinib is significantly better than patients being exposed to sunitinib. So there is now an inclination to potentially choose the actual line of treatment or the actual agent of treatment based on the molecular alterations. Now, going back to the abstracts, and the first abstract is the compound IDRX42, and essentially this is also an oral agent, a drug that's taken by mouth, which actually is a specific ATP competitive type 2 inhibitor of tyrosine kinase KIT. It has a broad spectrum of activity, and in actual fact, its earlier design was presented by Dr. Suzanne George at ASCO 2 years ago as a trial in progress poster on the left-hand side. And without going into too much details, essentially this new compound is able to cover most, if not all, the commonly seen primary mutations as well as resistant mutations of GIST. You can see here in the middle diagram, in actual fact, it has good coverage on exon 11, exon 13, exon 17, exon 14. And in the lower graphs here, you can see that preclinically in the laboratory, it has very good activity. On the right-hand side, on the right upper corner, you can see the waterfall plot, of which actually was presented at the earlier CTOS meeting in 2023 of the same study, an earlier report of the study indicating the fact that most of the patients who are actually on this clinical trial was able to benefit from treatment with all these bars pointing downwards, indicating the fact that the tumors were shrinking in size. And also the spider plot here on the bottom right shows that patients who are responding seem to have a long duration of response as well. Now, the design of this trial is very similar to other phase 1 clinical trials where we're actually looking at the dose in terms of trying to design and find the right dose to take forward to further testing. We're really looking at the side effect profile of these drugs as well as its potential early efficacy. And essentially for this clinical trial, patients who were recruited were ones who had metastatic and or unresectable GISTs. They had to have known KIT mutations, had at least the use of imatinib, as well as a good performance status. And the report of this particular abstract is based on the phase 1 dose escalation study. So as you can see in the diagram in the middle, this is the first batch of patients who were actually recruited into the clinical trial. And this report included essentially the first 73 patients that were recruited into the clinical trial. This is just a diagram or a table showing the demographics of these patients. And again, most of these patients have had prior treatment, and quite a lot have had quite a few prior treatments, with about 70% of these patients having had at least more than or equal to 3 lines of prior therapy. And the KIT mutational status is also documented here at the lower part of the table. And this is the primary results of this particular presentation, which actually you can see again here on the waterfall plot on the left. Most of the patients continue to show evidence of response as sort of an update of the original results that were presented at CTOS. The partial response rate was documented at 23% for the overall population, but for patients who've only had one prior line of treatment, so second-line patients, the response was up to about 43%. The swimmer's plot on the right-hand side again shows the duration of treatment of these patients. And I think what's most impressive is the fact that most of these swimmer lanes actually have that purple triangle at the very end, indicating the fact that at the time of reporting for this particular study, these patients continue to be on the study and are continuing treatment. So I think as we progress and as we evolve in terms of the results of this study being promulgated later on, you would see that these lines would actually get longer and longer, indicating the fact that patients who are on the treatment potentially can be on it for a longer period of time. Also, again, very important is the fact that highlighted in the box in blue, you can see that a lot of these patients actually have tumors which have multiple mutations. And in actual fact, with the presence of these multiple mutations, including the resistant mutations, the use of this compound IDRX42 is also able to control their disease. Now, we will always have to balance the efficacy with the side effect profile of these particular drugs. And it seems as though the most common side effect are gastrointestinal side effects, which include, say, diarrhea, as well as nausea and vomiting. Granted, most of these are relatively low grade, but these are certainly side effects that we really should not forget about. And certainly when we're taking these drugs every day, the potential of having these side effects on a daily manner is something that we really have to consider. Having said that, most of the patients actually were able to have a relief of these side effects with dose reductions as well as dose interruptions. So I think there may be a potential for adjusting the dose later on should we potentially have this drug available to us. Now, the second study that I wanted to highlight was the study of NB003, essentially another oral tyrosine kinase inhibitor of KIT and PDGFR alpha in patients with advanced GISTs. This was presented by Dr. Lee. And again, by way of background, we know the resistant mechanisms that we see in GIST tumors, specifically for NB003, based on the preclinical study. Again, you can see that it has very broad coverage of the known primary mutations as well as resistant mutations that we see in GIST tumors, which at least based on the preclinical findings are potentially superior to some of the other currently active agents. Now, again, this is also a phase 1 study. So in the earlier part of the drug's development, the presentation by Dr. Lee really focused on the part 1 dose escalation part, looking at a small number of patients, increasing the dose as cohort of patients are being recruited, trying to find the right dose to be determined for phase 2 investigations, as well as to document its safety and tolerability. For patients recruited into this trial, very similar to what was presented in the IDRX42 trial, these patients must have essentially advanced metastatic GISTs who have had progression based on their prior treatments. And again, this is the demographics of the patients recruited into this particular trial, very similar to what we saw in the previous trial. Most of these patients have had quite a bit of prior treatment. Actually, in actual fact, some of these patients have had more than 4 or 5 lines of treatment prior to recruitment into this trial. And the adverse events or the side effect profile of this compound is a bit different from what we saw from the IDRX42 compound. Interestingly enough, it seems as though the most common side effect would be a blood test that is changed, which includes blood creatine phosphokinase or CPK increase. There are also some side effects which we routinely see in some of these tyrosine kinase inhibitors, including, say, edema or fluid retention, as well as some effects on the blood counts. But the GI toxicities that was seen in IDRX42 does not seem to be quite common in this particular compound. Now, looking at the responses, again, these are small patient numbers. The trial is also not completely geared or designed to look at response itself. But what you can see is quite similar to what we saw in the other clinical trial, patients who have had less prior lines of treatment seem to derive a better benefit in terms of better chance of response. This does make theoretical sense, because if there is less prior treatment, there are potentially less resistant clones or resistant mechanisms that's present. So if your drug is able to hit and kill the tumors, there's a larger chance or higher chance that you're able to have a good control. And in the small number of patients, or actually 2 patients who only had 2 prior lines of tyrosine kinase inhibitors, both of them, or 100% of them, actually had a good response. But as we have patients who have had more prior treatments, in actual fact, the amount of response actually seems to decline. So I think it's very important for us to sort of find out which particular group of patients, based on their prior lines of treatment, would benefit most in these clinical trials. And very similar to the other trial, as well as what Vishu have shown previously in some of the other drugs as well, I think what we always look for is a drug that has a good prolonged control of the patient's disease. Sometimes it's not only about the response rate, not only about the shrinkage of the tumors, but making sure that things are in check for a long period of time. And as you can see here in the spider plot on the left-hand side, patients who benefited continue to benefit for a long period of time based on the weeks. And the swimmer's lane, again, on the right, with the arrows indicating the fact that these patients continue to benefit. And again, another colorful waterfall plot, quite complicated, quite a lot of information here, but indicating the fact that most of these patients actually had some benefit. Now, it's very interesting that when we actually look at response rate, we're looking at a patient who has determined to be having partial response must have shrinkage of tumors of more than 30% in size. But it probably is an underrepresentation of the benefit that's being derived from this drug, because if you actually look at this particular waterfall plot, you can see the majority of these patients, although did not quite hit the 30% mark, did have shrinkage of the tumors. And I would argue that 30% is a relatively rudimentary, picked out of the hat, out of the air number. And I would argue that somebody who has, say, 20% shrinkage or even 25% shrinkage would probably be very happy and no different from somebody who has a 30% shrinkage in the tumors. Now, this is actually quite similar to another drug that's currently being investigated, although not fully highlighted during the ASCO conference. You may be aware of this particular drug, which is slightly in its later phase of testing in a phase 3 trial, which is the drug called bezuclastinib, which in combination with sunitinib in patients with advanced metastatic GIST. This is specifically a second-line clinical trial where patients have had prior imatinib, and in actual fact, prior public presentations of its data also indicated the side effect profile of this particular drug. The reason why I'm highlighting this is this approach of covering the primary mutations, as well as in this situation, because of addition of the drug bezuclastinib, you're able to cover some of the other secondary mutations, seems to be a common way of us trying to tackle the issues of drug resistance. And my understanding is the recruitment for this trial has just been completed. And in fact, the very last patient was consented, I think, earlier on this week. So it means that in the coming months, at upcoming presentations, hopefully we'll be able to find out some of the preliminary results of this clinical trial as well. So I think, with these particular abstracts, what we're really looking at in terms of approach is trying to cover the primary as well as secondary mutations. Of course, it means that there will be potentially more drugs. But at the same time, whenever we try to do that, we need to, of course, balance the toxicity profile of this approach, as well as whether or not this combination treatment can be well tolerated. And you can see that in most of these clinical trials, we're looking at the later line setting. But then I guess the next step would be, if these are proven to be active, is there a way of bringing this to an earlier line where patients are being treated upfront with newer drugs and not just imatinib? Now, I think we need more data to see whether or not this does really show an improvement in benefit. But this particular approach is actually being done in lung cancer, where originally or osimertinib or a drug called Tagrisso was approved initially in the later line setting, but because of its very good efficacy and its ability to cover some of the known resistant mechanisms of the first generation EGFR tyrosine kinase inhibitors, it's already been moved into front line. So I think this model is very similar to what we're seeing now in GIST. And I think potentially if we get the data that we have and we can make sure that it's a safe approach, this may be the future direction. We look forward to seeing more of these abstracts being presented at upcoming meetings. Now, shifting gears a little, aside from KIT or PDGFR alpha associated GISTs, we have a small percentage of GISTs which are driven molecularly not just by KIT and PDGFR alpha. This includes a group of GISTs which are known as STH deficient or STH altered GISTs, a small number of patients here, but in actual fact, this is a well-described entity where previously there really have been no good drugs to target. And the prior use of tyrosine kinase inhibitors that we typically use for KIT or PDGFR alpha GISTs don't seem to work in this particular population. And as we do more and more molecular testing for GISTs, the LifeRAF group, which is the patient advocacy group for our GIST patients, have also documented in their prior presentation the fact that we are actually identifying more and more of these STH mutated or STH deficient GISTs in our community. So I think there is an urgent need for us to find the right treatment for this particular group of patients. Now, as I mentioned previously, the classical drugs that we use in GISTs do not work well for STH deficient GISTs. Imatinib or Gleevec is a drug that is ineffective. Now, there have been prior clinical trials using some of the other agents, including sunitinib or regorafenib. There have been some responses, small numbers, but maybe it's because of the fact that these drugs are multi-tyrosine kinase inhibitors with multiple targets, and it's probably by virtue of the fact that it also attacks VEGF, which may lead to some shrinkage of the tumors. Now, what we also know is that STH deficient GISTs are actually quite different clinically and in terms of their presentations as opposed to non-STH deficient GISTs. We're really talking about younger patients. There's higher preponderance for females, and in actual fact, the chance of having lymph node involvement is actually more common in STH deficient GISTs. Interestingly enough, in general though, the nature of the disease is generally a bit more slow growing than GISTs with intact STH, which means that the natural history of these diseases are somewhat different as well. And the third abstract is an abstract of this drug known as ovorambatinib. This is a third generation tyrosine kinase inhibitor. In actual fact, this drug is already approved in the treatment of tyrosine kinase inhibitor resistant CML or chronic myelogenous leukemia in chronic phase in China. And the initial results of this particular trial was presented at ASCO 2 years ago. And at that particular point, they were actually looking at a large group of GIST patients, including those of the classical KIT or PDGFR alpha mutations, as well as the STH deficient mutations. What you can see here in the bottom right-hand panel is the fact that the light blue color are the patients who are of STH deficient GISTs, and these patients actually, again, seem to benefit a lot more, and they were able to be on treatment for a longer period of time, whereas the classical mutations, including KIT mutations, which is the green swimmers bars, most of these patients actually stopped treatment quite early on, indicating that this drug probably is really mainly effective in just STH deficient GIST patients. Very busy slide here looking at some of the side effects of this particular compound, but suffice to say that most of the patients actually had, if they had side effects, were of relatively low grade, with very small numbers having grade 3 or above toxicities. And the median treatment duration was up to about 16 months in this particular trial. And looking again at the waterfall plot and the swimmer plot for this particular compound, I think it's quite impressive, indicating that most of the patients, again, had some shrinkage of the tumors. And a lot of the patients, as you can see in the swimmer's plot on the right-hand side with the green arrow, indicating the fact that they were continuing on treatment at the time of reporting. So there is a clear signal of activity in STH deficient GISTs with the use of overembatinib, long duration of ongoing treatment response. What we also know is that because this drug is already approved in other indications such as CML, we know the toxicity profile or side effects profile of this particular compound. Now, my understanding is there's a potential to move on to a phase 3 clinical trial and to really try to get this drug registered for GISTs or STH deficient GISTs. The question is there really a need for us to do this particular trial, given the fact that the STH deficient GIST is such a rare entity, and with this amount of information that's already available, is there a way of asking our regulatory authorities to have this drug approved so that we could get access to this drug early? Specifically, actually, overembatinib has a breakthrough therapy designation for STH deficient GISTs in mainland China, and we are actually looking at potentially what the regulatory authority will say based on this clinical trial to see whether or not there's a need for a phase 3 clinical trial. Now, one more important abstract, and again, I'm aware that I'm going slightly over time, but aside from GISTs and aside from the abstracts that Vishu had presented earlier on, I think there's one more important one that was presented at ASCO this year that should be highlighted to the community. And this is an abstract specifically on an entity known as tenosynovial giant cell tumor, TGCT, also previously known as pigmented villonodular synovitis. It is a locally aggressive neoplasm affecting the young population. Typically, it's a disease of the joints, which leads to inflammation and destruction of the joints. And many of these patients, when they have the disease, actually have quite significant symptoms. It affects their daily living because it causes a lot of pain, a lot of swelling. With the joint swelling, it limits the movement of the joints and it causes stiffness. And overall, it really impacts the quality of life. Now, the chance of it changing into a metastatic disease is extremely rare, and usually, to be honest, it's a non-life-threatening condition, but at the same time, it does significantly impact a patient's quality of life. Now, interestingly enough, in the more recent years, we are able to understand the mechanism of disease of this particular entity, and we know that CSF1 plays a critical role in the pathogenesis of tenosynovial giant cell tumor. And about 2 years ago, a group of experts around the world also published their management consensus guideline of this particular entity. And we also know that by addressing the CSF1 pathway, either through the use of monoclonal antibodies against the CSF1 ligand itself, or the receptors on the cells, or even tyrosine kinase inhibitors affecting CSF1, these have been approaches which we've been using to try to control this disease. And based on prior clinical trials, and this is before the use of pexidartinib, which is the drug that is FDA approved for the use in TGCT. The older clinical trials actually included drugs which we're familiar with in the GIST community as well, including, say, imatinib or linotinib, and these have a variable response rate. The monoclonal antibodies seem to do a bit better in terms of response rates, but actually none of them actually made it to clinical use. And many of these reports were of smaller patient numbers, and the median progression-free survival or duration of response were actually typically also not reported as well. Now, Dr. Bill Tapp from Memorial Sloan Kettering actually presented the MOTION trial at ASCO, which is the trial here on the right-hand side, which is a phase 3 randomized double-blinded placebo-controlled study in patients with inoperable TGCT. And the reason why this slide looks like this right now is because, in actual fact, Dr. Tapp also presented the the primary results of pexidartinib at ASCO about 6 years ago, which actually had a very similar design. Essentially, pexidartinib and vimseltinib are actually quite similar drugs. And both of them are essentially tyrosine kinase inhibitors that affects the CSF1 pathway. And you can see the design of these clinical trials are actually quite similar as well, where patients actually with TGCT were randomized to either receive the investigational compound, so either pexidartinib 6 years ago or vimseltinib in this particular trial versus placebo. And interestingly, for the first part, where in the first 24 weeks of treatment, this was a double-blinded approach. And then subsequent to the 24 weeks, the label was open, so patients are then able to find out whether or not they were on the active drug. And if they were not on the active drug, they were allowed to cross over to the active component. And this is a comparison side by side of the trial 6 years ago with pexidartinib versus the MOTION trial that was presented at ASCO. And without going into the finer details, what I really wanted to impress upon everyone is the fact that we also now have another compound which is active in this disease. You can see based on the waterfall plots that most of these patients, again, seem to benefit from treatment. And if you look at the actual numbers in terms of response rates, based on these two clinical trials, again, it's very comparable as well. But I think it's important for us to consider that in TGCT, the responses, of course, are important, but what's most important also is how it can improve the quality of life of our patients with this disease, which typically is a major concern. And what you can see here is the fact that with the different patient-reported outcome instruments that's made available to us, again, patients who are on vimseltinib had significant improvements in their quality of life, as well as their patient-reported outcomes. There have been improvements in the range of motion, stiffness, as well as the pain control as well. But I think there's a clear advantage of vimseltinib, which is this MOTION trial, as opposed to what's already FDA approved, which is pexidartinib, is the fact that with pexidartinib, in actual fact, there have been reports of liver toxicities, whereas with vimseltinib, there have been no evidence of cholestatic hepatotoxicity or drug-induced liver injury. So potentially this is a safer drug. And we, again, look forward to potentially having this made available in clinic for our patients. Now, there are about 6% of patients in this trial which actually have to discontinue treatment. We don't exactly know why. We know it is due to TEAEs or treatment emergent adverse events, but I think we do need more details as well. So there are some remaining unanswered questions for TGCT. I think the question is, we have now drugs which can lead to very good responses. And if that's the case, is there still a role for surgery in such situations? What is the optimal treatment duration of these patients, given the fact that these are relatively younger patients? It's not a metastatic disease, or the chance of it spreading to other sites is very, very unlikely. So do we treat until the disease control is at its best, where there's a response plateau, or do we treat it for a certain period of time and then consider stopping treatment? Because of course, having the treatment on for a long period of time also affects potential side effects, also affects, say, pregnancy or fertility plans for some of our patients as well, not to mention the potential financial toxicities of going on for a long period of time of treatment. And what is the cost-benefit ratio of some of these novel agents, including, say, pexidartinib or now vimseltinib, versus some of the older tyrosine kinase inhibitors, which such as imatinib, when we don't really know how long the treatment needs to be? There have been no head-to-head comparison between the old drugs and the new drugs. And certainly from where I practice in Hong Kong, for example, imatinib is now a generic medication. So in actual fact, the cost is relatively low. And if we are able to generate very similar responses or close to similar responses to some of these new agents, which inevitably will be very expensive, how can we make sure that we are able to do this in a cost-effective manner? So I think what this really calls for is some sort of international collaboration to generate some of the and document some of the real world evidence of the use of some of the older drugs as well as some of the newer drugs to really have a more contemporary collection of data and to really see whether or not these new drugs do potentially outperform some of the older agents that we routinely use in our clinic. So with this, I think it's a good time for me to end. I do apologize for going slightly over time. Just a quick shout out of the fact that the most important sarcoma meeting of the year is coming up shortly. And this would be held in November. CTOS this year will be back in the United States and certainly in sunny San Diego. And we look forward to, of course, welcoming, of course, physicians, clinicians, but also the patient community to come attend the CTOS conference as well. It's essentially a 3 to 4 day conference, very intensive sarcoma, a deep dive education. And at the end of the day, sarcoma physicians as well as patient advocates and patients are very collegial, so you'll have a great time there. So thank you.
Thank you so much. I appreciate everybody sticking around with us for what was really some wonderful review of really important work that was presented at ASCO. We do have a couple of, I think, important questions that are worth talking about. So if you have the time, I would appreciate if you could stick with us for those. I think I'm going to start with one that's pretty general, but I think important. Several of the studies that were mentioned seem to talk about patients with specific mutations. How do I know if I have a mutation that might make me eligible for a clinical trial?
For me or for Visu?
For whoever has a good answer, but I would appreciate hearing from both of you, and I think all of our participants.
Sure. Maybe I'll start off, and I think specifically this is probably more pertaining to the GIST population. And I would think that, yes, that's a very important point. And to begin with, probably I haven't emphasized the most important point about GIST treatment nowadays is the fact that we want to make sure that all our patients have their tumors profiled. Because we know that GIST is a heterogeneous disease. And I think previously this probably has not been pushed or it's been relatively understated because there were limited treatment options. Most of the patients would get imatinib and second line setting was sunitinib, and that was probably it. But now, given the fact that we do have a myriad of drugs already FDA approved, not to mention there are more drugs in the pipeline, we know that each of them do have different characteristics based on the coverage of the resistant mechanisms. So I think it's very important for us to know what the molecular profile of the GIST is. Now, there are different time points in a patient's journey where this is important. So of course, in the initial diagnosis, it's important, but also I guess in situations where you're already exposed to one treatment and you're seeing evidence of resistance, re-biopsy or maybe doing a liquid biopsy to find out whether or not there are potential resistant mechanisms, which one subsequent drug may be better than another, is an approach that we think theoretically makes sense. But we don't have the mature clinical trials to really show that this is necessarily correct. So I think work is being done, but I would think that based on, again, our experiences of other cancers, including, say, lung cancer, where we are taking more and more of this approach, I would think that this would probably make sense as well. Lastly, I think the very important point about profiling in the very beginning is because we certainly have an indication of the use of adjuvant treatment, so immediately after surgery for high-risk GIST patients. Now, 85% of our GIST patients will potentially benefit with imatinib because they're either KIT or potentially even a small number of PDGFR alpha patients. But we also know about 15 to 20% of the patients would not necessarily benefit. And to subject these patients to a 3-year duration of treatment when we know that it would not work, in actual fact, is also not fair. So I think it's important for us to really understand the molecular characteristics of the GIST tumors in all our GIST patients.
I would also, I think, just add, not every center has the resources or capabilities of doing a lot of these. I think as next generation sequencing has become more prevalent, there are many commercial tests that are available. And so those are often covered to some extent by the insurance, or there can be a negotiation that kind of comes back and forth. The one caution I think I would express there is to make sure that the genes of interest are being tested. So you can do very focalized. So if you have a GIST, you can do a very GIST specific panel, and that may not capture everything. So, I think for GIST, you really want to look at PDGFR alpha, SDHNF, those kind of genes. But when you look at like soft tissue sarcomas as a whole, it's often a good idea to kind of capture a wide net, especially as many of our clinical trials, especially in the early phase, are moving a little away from just looking at histology, but also looking at molecular profiling. And so I think we're going to see a more robust effort to really capture this, especially in the metastatic setting, even when diagnosed early.
That's really helpful. Thank you. I'm going to sort of combine two of these questions because I think they're related and similar. So there are a few mentions of studies that did not have enough statistical power to detect a difference between groups or treatments. And then there was also a point about a trial not being considered positive, even if it seemed like some patients benefit. Can you discuss what this means and how endpoints are significant in this context? No, that's a hard question.
I'll let Vishu start.
I think Herbert and I could probably speak on end for this.
I promise it'll be the last one for today.
I think, to keep it succinct, we design our clinical trials with a couple of assumptions. And the problem is when those assumptions are wrong, either because we are outperforming historical cohorts or controls, or for whatever reason, we don't expect the appropriate enrollment or any of these features, we may not have the power to detect a signal that is there, or we may, because of a smaller population, overrepresent just by pure luck a good response population. That's why we always go from a phase 1 to a phase 2 and hopefully to a phase 3. I think where these statistical considerations become really critical is when we are arguing with the FDA for approval so that insurance will cover. I think even with, quote, negative trials where we don't meet statistical significance, sometimes we're able to negotiate with insurance companies or with companies and just say, listen, there's not a lot of other options. Some people benefited. My patient resembles the patients who seem to benefit. And so when we do these, what we call sub-cohort or subpopulation analyses, there is always a danger that we are not meeting statistical significance, and that is not the intention of those analyses. But it may give us signals that we can then better design future clinical trials so that we can get a positive trial, so that we can argue with the FDA and say, listen, this is a positive trial. This drug should be made available to all patients outside of a clinical trial context. I know there's plenty more I can say, but I'll pause to give Herbert a chance.
No, I think that's a great way of putting it, and I think the point would be for any clinical trial, before the trial can happen, we need to have had made statistical assumptions. We need to assume how much benefit or how much additional benefit these new drugs may bring compared to the old drugs. Now, the biggest issue is sometimes we don't really fully understand how good our current treatments are, because we're basing ourselves on data that were generated maybe a decade ago, a decade and a half ago, even 2 decades ago. And certainly we know that, the outcome of sarcoma patients have not been great over the last 20 years. We haven't had much improvement, but there have been improvements, and actually more and more. In actual fact, the interesting part is the control arms of some of the more contemporary trials show that your standard doxorubicin, given as a single agent, has to be given it in 2024 is way better than when you had it, say, in the 1990s, even if it's the same drug at the same dose. And I think as a community, for us to design these trials, we have to have contemporary information of how good our current treatments are. But sarcomas are relatively rare. They're treated at multiple centers. Different centers also do things differently. So it sort of goes back to the very last slide that I presented about how we need real-world evidence generation to make sure that we have a good and level reference point for all these sarcomas that's treated internationally at this point in time in 2024. So then we design the trials with the right statistical rigor. So unfortunately, what happens is the designs were done with probably not robust statistical rigor. So the drug is an active drug. You see the shrinkages, you see the drops in the waterfall plots, but because it didn't meet the predefined percentage of improvement, things are called negative. And unfortunately, in the real world, drug companies already invested a lot of money in this particular trial. Then to try to get them to invest more to redesign is very difficult, and they will just move on to another compound. So I think the onus is on us as the communities to try to improve this situation.
Thank you, both of you, for trying to tackle that. I think we'll go ahead and wrap up with that. So thank you both for taking the time to be with us today, for sharing your expertise and the key takeaways from the ASCO meeting. I know that was a lot of information, and we all appreciate hearing it from you and hearing your important conclusions. And certainly we appreciate all that you do for the sarcoma community, both independently and together. And thank you to everyone who logged in today to be part of the discussion and ask your questions. As a reminder, today's session was recorded, and a link will be posted to SFA's website within the next few days at curesarcoma.org. And this now concludes our discussion. Thanks all.
Thank you. Bye-bye.